So in our last topic for the semester, we're going to talk about psychological and biological treatments for some of the disorders that we discussed in the last week. So our roadmap, we're going to talk about what is psychotherapy versus biomedical therapy. And then the bulk of this module will cover some specific forms of therapy. So we'll talk about insight therapies, we'll talk about group therapy, and we'll talk about behavioral and cognitive behavioral approaches. So let's start off by understanding what is the difference between psychotherapy and biomedical therapy. First up, psychotherapy is a psychological as opposed to medical intervention that's designed to help people resolve emotional, behavioral, and interpersonal problems and to improve the quality of their lives. Psychotherapy involves communication between patients and therapists that's intended to help people find relief from emotional distress, being less anxious, less fearful, depressed, seeking solutions to problems in their lives, and modifying ways of thinking and acting that prevent them from working productively and enjoying personal relationships. There's over 500 brands of psychotherapy, and the link you see where it says psychotherapy, how it's a hyperlink, that will take you to an APA webpage that details just a few of the different types. And we're going to touch on a few of them in this week as well. But I do want you to know that there are a lot more forms of therapy than what we'll actually be able to talk about. 20% of Americans have received psychotherapy at some point in their lives, which has probably even increased over the past few years. We know that females are more likely to seek out therapy than males, and as well as Caucasians are more likely than minority groups. But research shows that therapy can benefit all these groups equally. So while there are some ethnic and gender differences in terms of who seeks out or attends therapy, there's not really differences in effectiveness. That doesn't mean that everyone benefits the same. Of course, there's some individual differences in how well therapy is going to work for you. People who are better adjusted to begin with, are more motivated to work on their problems, or who realize that they are a part of the problems that they're experiencing, and who have a choice in the type of therapy that they're getting, all tend to fare better in terms of improvement. Psychotherapy varies from type to type, but typically begins with some discussion of a person's background and the concern that led them to seek help in the first place. Following this initial assessment, the patient and therapist then come to some sort of agreement, typically called a treatment contract. This contract specifies the goals of treatment, procedures, and a regular schedule for the time, place, and duration of the treatment sessions. Sometimes it's written down explicitly, but more often than not, it's just a verbal agreement that's discussed between the patient and the therapist. So, does it work? Right? We spend all this time talking about therapy. Is it effective? Well, prior to the 1970s, there was considerable controversy surrounding the issue. Many people thought that it wasn't useful or helpful. And in fact, there's still quite a bit of stigma surrounding mental health therapy today. Excuse me. But meta analyses showed that therapy does work in alleviating human suffering and in improving negative behaviors. Meta analytic studies, which are when you take a whole bunch of published studies and you put them all together and you sort of look at you do statistical analyses on the overall picture. These types of studies have grown over the years as our statistical techniques have become more advanced, which lets us look at trends in a more sophisticated way and provides us with more data and knowledge about what is and is not effective. So, while of course there's always a little bit of gray area to a question like this, the broad answer is yes, psychotherapy works. So, what I want you to take a look at is this graph where there's two normal distributions that are derived from about 500 different studies of psychotherapy outcomes. On the left, the blue portion is people with no psychotherapy. On the right, the pink is people who did receive psychotherapy. So you can see across a number of different treatments and samples, about 80% of people who received therapy actually reported better outcomes than people who didn't. So the next question becomes which forms of psychotherapy are effective and are they different for different people with different disorders? And we'll talk a little bit about that later on. But ultimately, while we are reasonably confident that psychotherapy is effective at mitigating negative mental health outcomes, we still have a lot of work to do in terms of understanding individual differences in psychotherapy. It also matters how good the therapist is. And so there are some characteristics and qualities that make someone an effective therapist. They need to be warm, direct, and empathetic. They must establish a positive working relationship with their client. They have to make the client feel safe, supported, and validated in order to get anywhere in the therapeutic process. They tend not to contradict clients. Instead, they find ways to communicate things that the client may not want to hear, but in a gentler way. They select important topics to focus on in session to keep things on track. So while the session usually involves a lot of the client talking, it's the professional's job to guide and focus the conversation and sort of keep things on track. And they match treatments to the needs of the client. Every client is going to have different needs. And so a good therapist will not only be able to identify those needs, but to adapt their approach in order to best fit them. Although many forms of psychotherapy are effective, there are some potentially harmful ones that exist, that many of which are still used today, even though they're not condoned by current therapists, research, or the APA. So, we talked way back in the beginning of this semester about facilitated communication. This was used with nonverbal children, where a facilitator would move the child's hands around to presumably type messages. And research has since found that that was bogus. Another example are scared straight programs. These are programs that are designed to deter juvenile participants from future criminal offenses. So the principle is that participants would visit inmates, they would observe firsthand what prison life was like, and they would interact with incarcerated adults. Now, these programs are popular in many areas of the world. And so the idea is that juveniles who see what prison is like will be deterred from future violations of the law. They'll get scared straight, right? But evidence actually suggests that scared straight and similar programs are simply not effective in deterring criminal activity. In fact, these types of programs may actually be harmful and actually have shown an increase in delinquency relative to no intervention at all among the same youth. Another example is the Drug Abuse Resistance Program, or DARE. This was something that's typically taught in elementary schools. Did any of you have that? I did, but I'm a little bit older than you guys, so maybe it's not going on as much anymore. But I remember there, a police officer would come into our classroom and would talk to us about drugs and alcohol. And the elementary version is taught in roughly 75% of all US schools. And so the police officers are used to teach students about the physical and social effects of drug use. So the goal was to build decision-making skills by helping children learn how to resist peer pressure, resist drugs and alcohol. But for all its good intentions, several studies found the elementary program alone had no effect on youth drug use. Perhaps they were starting just a little too young. And while DARE offers programs for junior high and high school students, most schools only use the elementary version. They don't use the later version. So there is growing evidence that the elementary programs alone can't impact use. But if we're not implementing them at the later ages as well, then kind of what's the point? Unlike psychotherapy, which are not physically invasive, biomedical treatments attempt to directly alter the brain's chemistry or physiology in order to treat psychological disorders. Psychopharmacology, it's a mouthful, is the use of medication, and this is the most widespread form of biomedical therapy. It began with the use of thorazine in 1954 for schizophrenia, but today antidepressants are actually the most commonly prescribed medications among adults. For virtually every disorder that exists today, there's a medication available. Some patients prefer to use medicine to treat their disorders, others prefer psychotherapy. Some use a combination of both. They're not mutually exclusive. You can both take medicine and participate in psychotherapy. And people often go through a number of iterations. So maybe they started with a therapy, then added in medication, then stopped taking the medication. You kind of have to bounce around a little bit to figure out what combination or cocktail, they often say, works the best. Treating mental health disorders is a highly individualized process, and it can take a while to find just the right balance of strategies that will be effective. Electrical stimulation is also used as a form of biomedical therapy. Electroconvulsive therapy, or ECT, involves brief electrical pulses to the brain to produce a controlled seizure. There are typically 6 to 10 treatments given 3 times a week, and they're used to treat very severe problems like intractable depression or schizophrenia as a last resort. You typically wouldn't try ECT unless you tried pretty much everything else and were at your wits' end to find some relief for your patient. Unsurprisingly, it's a much riskier treatment than medication or psychotherapy, hence why it's used with much greater discretion. And despite negative media attention and stereotypes surrounding ECT, most people who undergo the procedure actually do report improvement and say that they'd use it again. But it's not a cure all. About 50% of people do experience relapse after 6 months. So even though they may experience some initial relief, there's debate about how long it lasts. There's also some side effects to consider, such as memory loss and confusion, but overall, it exists as an option in some extreme cases. And lastly, psychosurgery is brain surgery to treat psychological disorders like a prefrontal lobotomy. These were more common many years ago. They're far less often used today and tend to be only as an absolute last resort and only with a handful of conditions, things like severe OCD, depression, or bipolar disorders. The benefits rarely, if ever, outweigh the risks. People can end up with severe impairments in memory, changes in personality, or diminished creativity. So, brain surgery is about as invasive and risky as it gets. So, when it's conducted, there are a number of checks and balances put in place to make sure that it really is the appropriate way to go in terms of treatment. Although pharmacology has its uses, it's not a cure all, and most medicines have numerous side effects that need to be weighed when you're considering what treatment to administer. Most side effects will dissipate once you stop taking the drug, but not all the time. There are some examples of negative side effects that persist even once the medication is stopped. There's also differences in drug response to dosage. One dose does not fit all, so things like weight, age, gender, and symptom severity can all affect drug response. We know that African Americans tend to require lower dosages of depression medications than Caucasians, and Asian Americans tend to have lower metabolism for some medicines compared to others. So there are many things that need to be considered, and pharmacology should really only be administered by a trained psychiatrist or physician. There's also some questions about efficacy and safety of some things like SSRIs or selective serotonin reuptake inhibitors in children and adolescents. So we don't need to get into the nitty gritty of this, but the FDA actually requires drug companies to put warnings on SSRIs because they've been shown to increase risk of suicidal thoughts among children and adolescents who take these medications. So again, things like age and safety are very, very important. Overprescription tends to be a concern for a lot of people, and we particularly hear this in the context of ADHD medication. So there's this notion that everyone today is over medicated and we just throw medicine at every disorder in the hopes that that will solve it. There's different schools of thought on this. What I will say is that we do have to be careful about dishing out prescriptions when they aren't necessary or helpful. Medication has its uses, it has its place, but there are also other times where you are better off not using it. And only a psychiatrist can really help you to make those decisions. And polypharmacy or prescribing many medications at the same time is also something we need to be very aware of as it can be dangerous. So medications can interact or play off of each other in negative ways. So if people are prescribed multiple drugs that interact with each other in harmful ways, that's something that we need to be aware of and is something that a licensed psychiatrist would know about when prescribing different medications. So in the next section, we're going to get into some of the different psychotherapy strategies. And so up first, what we'll talk about is insight therapy.